call Shilpi back again. Dr. Prashant was supposed to be here, but he's got a viral fever, so he's not this. But he sent his talks, and Shilpi will be talking on behalf of.
So good morning once again. So now I'll be speaking on recurrent macular holes. So by definition, what is persistent or refractory macular hole? It is the failure of the hole to close after primary surgery. And what are recurrent macular holes? They reopen after the successful closure. The incidence is 4.8 to 9.2%, and usually the timing of recurrence is 12 to 15 months post first surgery. The various causes are found, and the most important causes are that in cases of pathological myopia, there are high recurrence cases. If there are intraoperative retinal tears which are not managed or addressed properly during the first surgery, they can contribute to the opening of the macular holes. Cystoid macular edema due to any cause, be it after the cataract surgery or any of the reasons, it can lead to the reopening of the macular holes. Post-surgical complications, recurrent epiretinal membrane can pull the macula and create a recurrence of the macular hole, and leftover traction by the vitreous is the another cause for the reopening of the macular holes. So what are the treatment options available? If the macular hole or the retina is patulous or elastic and pliable, you can simply drain the SRF or do the hydrodissection or can use the autologous serum. But if it is associated with the PVR, we need to address that issue also. We should remove the star folds. If needed, we can do retinotomies, retinectomies, and even in the GRTs, we need to do the relaxing retinectomies. Now coming to the grafts, we can use the ILM graft, retinal grafts, amniotic grafts, even the lens capsular grafts. And in the last resort, when there is nothing to do and RP is very unhealthy, so as a last resort, you can even do the endolaser to the edge of the macular hole in cases of the recurrent cases. So what to do when the residual ILM is present? So this is a case we always put the BBG before proceeding for the surgery in a hope that there is any residual ILM present there. So in this case, there was the recurrent epiretinal membrane and the ILM was not peeled. So it was used and the inverted flap technique was done. So in inverted flap, ILM flap remnant, it's the hinge to margin the macular hole. Even if you have a little bit of the ILM remaining, you can use it to invert and fill the gap. So various modifications are done, like even you can use the autologous platelet concentrate over the ILM flap. Texas taco technique also can be used, and you can also use the nerve growth factor so that the surgical success is increased. So this was the another case. She had the recurrent macular hole, and after staining, we could see that the inferior ILM was not there, but superior ILM was there. So the ILM was peeled and the flaps were made. An inverted flap technique was done, followed by fluid gas air exchange and the tamponading agent. When ILM is not present, so what are the options available? You can do the hydrodissection. I'm sorry, we don't have the video of this. In this, we use the balanced salt solution and it is injected all along in the 4 quadrants around the macular hole. You have to create the bleb so that it pushes the retina, it makes it more pliable, and following fluid gas exchange, the macular hole close. You can also do the relaxing retinotomies to release the tangential traction, but there is higher risk of vision and visual field loss with this technique. And this is usually reserved as a last surgical options where all other options have failed. Autologous ILM transplant is used when there is no ILM near the macula. Preferred site of harvesting is within the vascular arcades. Major challenges is keeping the free ILM flap in place. So usually bimanual surgery plus PFCL is used to increase the success of the surgery. Amniotic membranes are used similarly in these cases also. Preferably it should be bimanual and under the PFCL. Lens capsular flap technique is also used to fill in the macular holes. In the phakic eyes, after doing the phacoemulsification and implanting the IOL, you can harvest the anterior lens capsule during the capsular excess. But in cases of the pseudophakic eyes, when there is no remnant of, or you cannot use the anterior lens capsule, you can use the posterior lens capsule. But it has been seen that the anterior capsule flap has a better closure rate compared to the posterior capsular flap. Autologous serums can be used during the surgery, and in this the serum is injected directly onto the macular hole. So this is a video of the patient who underwent ILM peel in elsewhere, and then there was a recurrent opening of the macular hole. So after putting the dye, there was no ILMs, fluid gas exchange was done. And after doing the exchange, a drop of serum was put directly over the hole. And then the FX was completed. And this is the post-operative picture at the 2 months and at 6 months. So this was a case which was operated for macular hole, but there was recurrence with the macular folds and this PVR changes. So after removing the membrane over the macula, even the peripheral fibrous tissue, it has to be tackled, else you will not get the closure of the macular hole. Once all the traction is relieved, the macular hole, it closes by itself. There was no need of any transplant of the ILM from the same site or the anything. Just the milking of the fluid and the macular hole was closed. And this is the post-operative picture of this patient at day 1. This was a case where there was anterior PVR which was not letting the macular hole to close. When the dye was put, there was tits and bits of ILM which was remaining. It was peeled off, the PFCL was put, rest of the membranes were removed, relaxing retinectomy was done, and after it was done, the macular hole closed. Now, neurosensory retinal graft. In this case, the harvest site is usually the superior to the superiotemporal arcade, and in this, yes, you always have to do the bimanual surgery under the PFCL. The most common complication seen is the graft displacement regardless of the tamponading agent. So this is the one case. This is the preoperative picture. You have to use the 41 gauge needle to create a bleb. Do the endolaser surrounding the bleb. Cauterize the inner margin, and then the flap is created. The neurosensory graft is created. Cauterize the bleeders. And then put the chandelier, put PFCL. After putting the PFCL, you have to cut the last hinge of the neurosensory graft. It is moved from the harvesting site up to the macular hole. Touch-up endolaser was done, fluid air exchange followed by the silicone oil tamponading. So this is the post-operative picture of this patient. Now, if suppose you have nothing to do, sometimes the simple maneuvers can lead to the closure of the macular hole. In this case, under the fluid, the subretinal fluid was drained. The major tip here is you should not touch the RPE. It should be always at the edge of the macular hole, because inadvertently if you touch the macular hole, you will create hemorrhage, and it can later on lead to the formation of the CNVM. So always your tip should be at the edge of the macular hole, and if it is a patulous macular hole, it will close automatically simply with these maneuvers. Now this is the last case in which it was the recurrent retinal detachment because of the reopening of the macular hole. There were no peripheral breaks, nothing. So in this case, the fluid was drained through the macula only. Periphery was again examined, ILM was again stained to see. Fluid air gas exchange done. The residual fluid from the macular hole, it was drained under FAX. And we could see that it is closing slowly. The dimension of the macular hole was decreasing. On table, there was a closed macular hole after draining all the fluid. So because the RP is very unhealthy and it was the third recurrence in this patient, so the endo laser to the edge of the macular hole was done in a hope that it will create some adhesion and there will not be any fluid again into the macular hole, and again the touch-up laser in the periphery was done and the case was closed. Thank you so much.
Of macular hole, and I thank you for presenting his work also. Vatsal, you had a question?
I had a comment. See, in last 10 years, we had about 10 macular holes which I had operated and not closed. So over the years, what technique I have developed is that we have now Swepsos OCT, so you can do OCT after 4 hours of surgery also, and it gives a beautiful image of the whole area. So many times the patients do not maintain position. So what I have done is just do OPD-FG with C3F8 gas. There are two rationales that if patient has not maintained position, we insist on maintaining position and C3F8 remains for longer time. So sometimes hole may take longer to close rather than 5-6 days we normally use SF6. So at least 4 holes have closed with just OPD-FG, and these are vitrectomized eyes, so I think putting 1 cc C3F8 is not difficult.
You maintain position for 3 days or longer?
3 days, ma'am.
3 days. I think that's the general
So,
kind of.
but this is in cases of the primary macular holes. Sir, what is speaking about? But Vatsal sir, this is about the primary macular holes. I mean, what you were talking about to inject the C3F8 and then giving the prone position. In the primary cases, na, sir? Yes.
Yes.
Hello. What are you using ordinary laser treatment in the laser of the macula? In laser of your macula? The endo laser of your
Endolaser
macula.
yes, sir.
Is it in the edge of the
Edges of the macular hole.
edge of the macular hole?
Yes, sir.
And what kind of laser are you using? Is the same green laser?
Same green laser, sir.
So you will induce a scar in the macula then?
Yes, sir. But when there is cases of pathological myopia or when there is no RP, you are suspecting that RP is very unhealthy. In these cases, always the recurrence was because of the reopening of the macular hole only.
So you are assuming that the RPE underneath the macula is already non-functional. That's why you do laser treatment?
Sir, as a last resort, if there is always a recurrence just only because of the reopening of the macular hole, laser can create the adhesions.
Okay.
Have you done any of these posterior staphylomas where they have these macular
Ma'am,
holes?
not in cases of posterior staphylomas we do. This was